Today, I will talk about methods of treatment of refractive errors with particular focus on spectacles as it is the most widely accepted and needed in day-to-day practice. The effect of uncorrected or undercorrected refractive errors URE is different for children, adults and elderly. In children, URE may affect self-esteem, attention and learning. It may lead to amblyopia with associated loss of depth perception, impacting activities of daily living and loss of some job opportunities. In adults, it affects quality of life, productivity and has economic consequences. In elderly, it causes increased risk of falls, fractures, isolation and mortality. The community burden of disease due to URE in all age groups is significant. Looking at disability adjusted life years, the impact appears to be more in children. In children, there is an additional problem of symptoms not coming forth very clearly. It is therefore important to evaluate and appropriately manage refractive errors. The refractive errors are treated depending upon the clinical effects produced by them and visual needs of the patient. The common symptoms being frequent blinking or rubbing the eyes, vision diminution, working from very close, eye strain, difficulty in schoolwork and sometimes strabismus. Preschool children often do not complain, hence screening is important, especially for younger siblings of children with diagnosed refractive error. The treatment options may be non-surgical or surgical. In the non-surgical, there are spectacles, which are most common, widely accepted and non-invasive method, or there may be contact lenses. They are also in fairly common use. The surgical methods are invasive. Their use is dependent upon the individual's preference. They are used for selected patients, most often for myopia and sometimes for hypermetropia or presbyopia. They may be cornea based or lens based. We will focus on general principles and some guidelines for spectacle correction as it is the most accepted and needed method in everyday practice. We need to answer so many questions to the patients and to ourselves in doing so. Whether to prescribe or not, what number to prescribe, whether to change the existing glasses number, what is going to be the likely course of the error, what if one doesn't wear the required glasses, what next, that means what else has to be done. And especially in case of children, the parents need to be reassured repeatedly. The type of glasses required for correction of different refractive errors is illustrated in figure 1a, 1b, 3, 4a and 4b. Hypermetropia correction requires convex or plus lenses. Myopia requires concave or minus lenses. Astigmatism correction requires cylindrical lenses alone in simple astigmatism and along with the sphere in compound or mixed astigmatism. Presbyopia is corrected by addition of convex lenses over distant correction. Here we see in a hypermetropic eye, the bundle of parallel rays with relaxed accommodation gets focused behind the retina, and this can be brought to focus on the retina by the use of a convex lens. And in myopia, the same similar bundle of rays gets focused in front of the retina, and this can be pushed back by adding a concave lens in the spectacles. We have seen in figure 1a that hypermetropia correction requires convex or plus lenses. In children and young adults, the facultative component of hypermetropia is large due to strong accommodation as shown in figure 2. This needs to be relaxed by cycloplegia and fogging to uncover the manifest hypermetropia for proper correction. In children, small hypermetropic errors may be asymptomatic and require no correction as they can be compensated by the high accommodative reserves. All other situations we aim to provide a full correction. The required correction should be prescribed even if the visual reward is suboptimal. This I want to emphasize as often we see that when with the correction with glasses the vision does not improve optimally or improves only partially, it is mentioned no acceptance, hence glasses not prescribed. So this should not be done because the glasses not only allow the patient to have a good vision, whatever is his visual potential, but they also take care of the excessive accommodation that the patient needs to use, and they help in visual improvement. With advancing age, as the accommodation becomes weaker, more and more facultative component becomes manifest. Older patients may not need cycloplegia to uncover the manifest hypermetropia. They accept a hypermetropic correction more readily. We see here that of this total hypermetropia, there is a part of the hypermetropia which is controlled by the accommodation, and this is called the facultative hypermetropia. Now, as this accommodation is strong in children, the facultative component of hypermetropia is high, and as the accommodation becomes weaker and weaker with advancing age, the facultative component becomes lesser and lesser and lesser, and more hypermetropia goes on becoming uh, more obvious or goes on getting uncovered, and therefore it is easier in elderly population to prescribe the hypermetropic correction, and in younger population we have to make an extra effort to relax this accommodation. Myopia correction requires concave or minus lenses as shown in figure 1b. Individuals with low myopia have slightly poor vision for distance and good vision for near. They may not need eyeglass correction except for distance activities such as driving or schoolwork. The aim is to prescribe the lowest power that is needed for achieving good vision. Overcorrecting myopic patients is not recommended. It will result in need for excessive accommodation, which may create symptoms of eye strain. This is illustrated in figure 1c. The hypermetropic defocus is also believed to enhance myopia progression. Because of the progressive nature of myopia in childhood and adolescence, screening examinations that include visual acuity are recommended every 1 to 2 years. In myopia, the concave lenses shift the focus of the rays from in front of the retina to the retina. However, when we overcorrect hypermetropia, then this focus shifts from in front of the retina, not to the retina but behind the retina. This is the hypermetropic defocus. And for this, when this happens, the patient who is already not used to using excessive accommodation has to use excessive accommodation, and this causes eye strain. And this excessive need for accommodation is also believed to enhance myopia progression. High myopes have additional problem of vitreous and retinal degeneration. Always examine the retina for degenerative changes, especially in the periphery. treat or refer to a retina specialist if necessary. Appropriate spectacle correction, even if vision after correction is less than normal, should be given. Astigmatism correction requires cylindrical lenses alone in simple astigmatism and along with a sphere in compound and mixed astigmatism. Now if you look at this figure of simple astigmatism, one axis is emetropic and the other is myopic here and hypermetropic here. So in these cases you would require a minor cylinder to bring the focus of this axis to the retina, and here you would require a plus cylinder to get the axis of this axis focused on the retina. Now here, where both the axes are at fault, you would require a sphere to correct this axis and an additional cylinder to correct this axis. Here it would be a minus sphere and a minus cylinder, whereas here you would require a plus sphere to bring this focus at the retina and an additional plus cylinder to correct this. And in mixed astigmatism, you would require a sphere and a cylinder of opposite signs. Now this figure here, it is showing a cylindrical lens for correction of simple myopic astigmatism. Presbyopia is difficulty in near vision due to gradual decline in the ability to accommodate. This is shown in figure 4a. It becomes manifest around the age of 40 years when 0.5 to 1 diopter addition over distance number is needed. This need gradually increases by 0.5 diopters every 5 years to about 2.5 or 2.75 diopters addition at the age of about 60 years, again shown in figure 4a. For near working distance of about 33 centimeters, one does not need more addition than this. Try to give the lowest possible addition that makes the patient comfortable so that his accommodation does not get completely relaxed and he needs to use his own accommodation also. The amount of addition and how we will give it will vary with the patient's comfortable distance for near work, and spectacles should be modified as per the patient's need. Here we see that though the capacity to accommodate begins to decline at a very early age and continues as the age advances, the need for additional glasses for near work becomes clinically manifest at about the age of 40 years and continues to increase by about plus 0.5 diopters every 5 years to reach a maximum requirement of plus 2.5 or plus 2.5 or plus 2.75 addition by the age of 60 or 65 years. And usually we do not need to give a addition of more than plus 2.75 after that. The presbyopic correction is modified as per the patient's need, his comfort and acceptance. He may prefer to use single vision lens where he requires two separate glasses, one for distance and one for near. He may be comfortable with a bifocal lens which has a distance and a near correction. One may need a intermediate strip for intermediate working distance such as the computer screen, or he may be comfortable with a progressive lens where there is a gradual transition from the power required for distance to the power required for near. So depending upon the comfort, the patient and his need, the patient may be comfortable with any of these. After quantitative assessment of the refractive error, you need a lot of clinical judgment to prescribe glasses. Whether to prescribe or not to prescribe, how much to prescribe, and how to prescribe. And it depends upon the age of the patient, his refractive error, and the status of his ocular alignment. These are guidelines for prescription of glasses for preschool children given by the American Association for Pediatric Ophthalmology and Strabismus. So these are guidelines for isoametropia, anisometropia without strabismus, and oblique astigmatism. For that guidelines for hyperopia without strabismus and with strabismus are different. Same way for anisometropia without strabismus and with strabismus are different. Must remember that the threshold for prescribing glasses when these refractive errors are associated with strabismus is lower than when they are not associated with astigmatism, with strabismus. So, depending upon the age, these are the thresholds below which you need not prescribe glasses. And for oblique astigmatism, the threshold is 1 diopters. And what we consider as oblique astigmatism is when the axis is more than 15 degrees away from the 90 or 180 meridian. So just you see that for a child for less than 1 year or less than 2 years, if you find a refractive error of -5 or +6, less than that, less than -4 or less than +5, then there is actually no need to prescribe glasses unless it is associated with strabismus. For that, the thresholds are lower. Prescription of glasses in school age children is much easier because they are able to cooperate and subjective testing is possible, and also they come forth with their complaints, and the modification of glasses number also can be assessed along with the vision of the children. Now let us look at the guidelines for prescription of glasses in this age group. In mild myopia, the child has minimal complaints and his near vision is not affected. So prescribe glasses when patient complains of difficulty in distance vision or visual acuity is 20/30, that is 6/18 or less. In hypermetropia without esotropia, there is no need for glasses if there is low degree of error and is asymptomatic and well compensated by the accommodation. Prescribe glasses even if distance vision is good, that is 20/20 or 6/6, but is associated with poor near vision or eye strain. To begin with, you may need to undercorrect by 1 to 3 diopters to help acceptance of spectacles. But later, you have to prescribe as per the quantitative assessment. In hyperopia with esotropia, we have to give full cycloplegic correction. Here also, to help acceptance of glasses, in the beginning, you may need to undercorrect. In anisometropia, correct the difference between the two eyes to within 1 diopter. And in antimetropia, undercorrect the hyperopic eye by 0.5 to 1 diopter. So before we conclude, let us quickly look at the points that we should keep in mind while prescribing glasses. Remember, all refractive errors need not be corrected. Very often we see that we get a quantitative assessment of the refractive error either by retinoscopy or autoref, and you quickly prescribe according to those readings. But I would suggest that a lot of clinical judgment and other things should be kept in mind. The patient's need, and comfortable distance of work, his accommodation reserves, his ocular alignment, and rarely you may have to consider about ocular dominance. So apart from the quantitative assessment of the refractive error, you have to make your own decision depending upon these factors. While prescribing glasses, we need to take into consideration the ocular alignment and adjust the prescription within limits of patient's vision and comfort. The hypermetropic glasses relax accommodation and also relax convergence, whereas the myopic glasses induce more accommodation and more convergence. Therefore, in exodeviation, we undercorrect the hypermetropia and fully correct myopia, whereas in esodeviation, we fully correct hypermetropia and undercorrect myopia. Rarely, I would say very rarely, we have to look into ocular dominance. If eye strain persists despite best efforts and re-verification of the spectacle correction, look for the dominant eye and adjust accordingly. Correct the dominant eye for distance vision during monovision fitting and make adjustments during simultaneous lens fitting so as not to have poorer corrected vision in the dominant eye. Now, ocular dominance is rarely needed and rarely used in clinical practice and therefore not so well understood. It should not be confused with amblyopia or suppression in one eye. It is just a sighting preference. It is the tendency to prefer visual input from one eye over the other. It may be called eyedness as somewhat analogous to the laterality of the hands, the right or the left-handedness. Now, while the handedness, right or left-handedness is very obvious, the eyedness or ocular dominance is not so obvious and we have to look for it. How do we go ahead to look for it? I will describe here two tests for ocular dominance. One is the hand triangle test and the other is the +1 diopter lens test. Both the tests are very simple. The hand triangle one being simpler, of course, you don't need anything for that. With the hands, two hands, you make a triangle and look at any object through this triangle so that that object is placed in the center of your vision with both eyes open. Then you close each eye alternately and see what happens. Now, when you close the left eye and the right eye is open and the object remains in the center, that means that the right eye is dominant. And when the left eye is closed and the right eye is only seeing and the object does not remain in the center, that means that the left eye was the or is the dominant eye. So, to summarize, the object remains centered with the dominant eye open. Now, with the +1 diopter lens test, with best binocular distance correction in the trial frame, patient looks at the lowest line he can read. Now, this is the best correction in the trial frame, and then you put +1 diopter lens alternately in front of each eye, and patient indicates when the vision is clearest. If the +1 diopter lens is placed in front of the left eye when the patient reports the vision being clearest, that means that the right eye is dominant. And if the lens is +1 diopter lens is placed in front of the right eye when the patient says that the vision is clearest, that means that the left eye is dominant. So these are simple tests for ocular dominance, and in case your patient is unhappy with the best possible correction, you can look for it and make the needed adjustments. I conclude by saying that always supplement the findings of quantitative tests for refractive error with your clinical judgment based on the patient's need and other associated factors as described to prescribe suitably. Let us now revise and also test our understanding with the help of MCQs. You can go ahead to attempt these MCQs. The key is given at the end.